Amyotrophic lateral sclerosis, or ALS, has Greek roots meaning without nourishment to muscles. What happens when our nerve cells stop communicating with our muscle cells? Loss of signals to the cells. Tonight, On Call with the Prairie Doc. Hello, I'm Dr. Jill Kruse, your Prairie Doc host this evening. Tonight's episode of our 22nd season, providing health information based on science, built on trust. We continue to provide trusted health information this evening as we discuss ALS, symptoms, causes, and treatment. Joining us to address this topic is Dr. Tyler Jarris from Avera Medical Group, Palliative Medicine, Sioux Falls, and Dr. Nnamdi Uhegwu from Sanford Neurology Clinic. Welcome, and thanks to you for joining us today in the studio here in Brookings on the campus of South Dakota State University. So tell us a little bit about yourselves, Dr. Jarris.
Yeah, sure. So I, of course, work for Avera. I work in palliative medicine and hospice care as well. So I see patients with, chronic disease, chronic illness, and I provide sort of supportive care to patients and families, helping out with things like symptom management, advanced care planning. I'm originally from, South Dakota, grew up in Aberdeen. Went to school in the Brookings area, medical school here in South Dakota, and I've been practicing in South Dakota for the last 10 years or so, worked for Avera for the last 10 years.
Excellent. So coming home to campus here, it looks different though, doesn't it?
Yeah, it does. I don't recognize it at all. So,
all right.
Yep.
So, Dr. Nnamdi, tell us a little bit about yourself.
Yeah, I'm Nnamdi Uhegwu. I'm originally from Nigeria. Did my neurology residency training at Zvad-Fmk Medical Center in Edison, New Jersey. Also did a fellowship in neurophysiology there. Then before starting to work with Sanford. So I do neurology, neurophysiology, and see patients with neuromuscular disorders like ALS as well. So I do the EMGs, do the nerve conduction studies. We try to make the diagnosis, start off their treatment, discuss with them, and of course, involved with other providers in the multidisciplinary approach to care.
Okay. Excellent. Well, before we start our conversation, we invite you, our audience, to submit your questions about ALS. Viewers can contact us 3 ways. Call 1-888-376-6225, send an email to ask@prairiedoc.org, or ask on our Prairie Doc Facebook page. We will work to answer as many of your questions as possible, given the time available. Sometimes we receive more questions than we can cover, and we apologize if we do not get to your question. To encourage you to ask early, all questions asked in the first 20 minutes will be entered into a drawing for one of our Prairie Doc gift items. The winner will be announced at the end of the program. Your question will remain anonymous, but please provide contact information when you submit your question if you would like to be entered into the drawing for a Prairie Doc gift item. Well, gentlemen, ALS, it's abbreviated, but it's actually a bigger, kind of more of a tongue twister, that amyotrophic lateral sclerosis. I don't know why medical things have to have such tongue twister names, or as a lot of people call it, Lou Gehrig's disease. So, Dr. Nnamdi, how often are you seeing patients with this? Is this a fairly common diagnosis that you treat?
Yeah, it's surprisingly, common. Across the U.S., it's estimated that about 1 to 5 persons per 100,000 are diagnosed or living with ALS. So it's something that probably in my practice, we'll probably see one diagnosis maybe every quarter. So it has the same incidence as, say, something like multiple sclerosis, which people hear more about. So it's a rather more common disorder than we are giving it credit for.
Okay. And is there a country that has a higher incidence? Is it or ethnicity that has a higher risk for this?
So the data does suggest that it seems to be a little more common in Caucasians of European descent. And then there are some clusters. Data has found clusters in certain populations, like they talk about, but not in the U.S. Like Guam Island, I think, had particularly, higher incidence than the rest of the world for reasons that no one is quite sure. And then they talk about some areas in New Guinea that also had a relatively higher concentration than other parts of the world. But in the U.S. is a little more common among Caucasians of European descent than other groups.
Can you kind of explain what exactly is ALS? What does it do to the body?
So, like the name says, amyotrophic lateral sclerosis is just a play on what it does. So amyotrophy, just loss of muscles. So the muscles stop functioning, lose. Because they are not functioning due to loss of nerve supply to them, they shrink up, become atrophic. Clinically, the people lose function, what the muscles are supposed to do. And then the lateral sclerosis part, because on pathology, there is gliosis, or sclerosis in the lateral corticospinal tract. So I think back in 18-something, when Dr. Chakot gave the name, he used the clinical, what he presents with, which is the loss of muscle, plus what he saw in pathology, which was the sclerosis in the lateral corticospinal tract, and then came up with the name amyotrophic lateral sclerosis. But we also call it motor neuron disease now. Sometimes we use it interchangeably. So sometimes you hear people say motor neuron disease, although that's a little more of a spectrum, that includes a little more things than ALS. And then, of course, the Lou Gehrig's disease is called because of, Lou Gehrig's, who is a well-known baseball player that, was diagnosed with it in the 1930s, I think.
All right. Well, Dr. Jarris, talk a little bit about the patients that you see with ALS. How do you help them, and especially like mental health aspects, or?
Sure. Yeah, unfortunately, we see patients of all ages with ALS. We use kind of a multidisciplinary approach, kind of similar to like maybe an ALS clinic, but from more of a palliative perspective. So we're there to support patients from like the psychosocial perspective, because sometimes there's family or financial or just other social concerns happening. We're there to support them, with emotional needs, emotional distress, even existential concerns. If we can help them with spiritual concerns, we try to do that as well. Utilizing like our social work team, our nursing team, we definitely help with just like helping out with resource just sort of acquisition, if you will, helping out with in-home services and home care, and making sure that patients and families have what they need, even outside of what ALS and ALS Clinic and ALS Association sometimes has to offer. It's just kind of there for kind of a whole team approach, helping out the whole person. Just be helpful.
All right. Well, this kind of flows into a question we have from a caller in Sioux Falls. It said, to what extent does emotional well-being or mental health positively or negatively affect outcomes with ALS?
One thing we always pay emphasis on in medicine is that the human being is a whole. So even apart from physical things, our emotional well-being plays a role in how well we do with different disorders, not just ALS. And because ALS, unfortunately, is such it's a huge diagnosis, and maybe when we talk about it later, we don't have a cure for it. So that becomes an emotional burden on not just the patient, but also families of people who have been diagnosed with this. And the emotional well-being, if it's taken care of, helps the patient know that, okay, this diagnosis is not the end of the road, doesn't mean a death sentence. It doesn't mean there is nothing that can be done. There are ways of slowing the disease down. And the emphasis, like some people say, would be on life, not on the diagnosis of ALS. And that's where the emotional, that emotional support comes in. So the patient, still knows that, yeah, it's a degenerative disease with no cure, but it can be slowed down. The supportive care helps the person deal better with it, still enjoy what they need to enjoy. And those who do that will do much better than someone who just takes it as a death sentence and then just gives up on, the options that are there.
Okay. What are some of the ways or medications that we use now to try to slow down the progression of this disease?
So, we have 3 medications that are FDA approved for ALS. The oldest is Reluxol. So it's been around for quite a while. And what happens with ALS is that for some reason we have neuronal cell death. So the medications all try to, slow down the cell death. The Reluxol, it's a tablet that has to be taken twice a day, generally well tolerated, and it shows benefits by slowing disease. People who are on it compared to those who are not have a few months of survival benefit and delayed progression in functional decline. Had been around for a long time before. More recently, there is also Radicava, which is Edaveron. I shouldn't be using the trade names. So Edaveron is also approved. And that, again, all these, they work on reducing the cell death, which is what is the underlying pathology in ALS. So when combined with the Reluxol, there is added benefit. And more recently, I think September last year, the 3rd medication was approved, again, phenylbutyrate and Tarusadiol. That again showed benefit in slowing progression. None of this is a cure, but those who are on the medications have a slowing of functional decline, compared to those who are not.
Mm-hmm. And Dr. Juris, what sort of things do you do with palliative care to help kind of support patients and treat the symptoms where you're not treating the disease, but the impact that it's having?
Yeah, I think you're exactly right. I want the patients that I'm seeing to be as successful as they possibly can, and really that's a lot of what we do in palliative medicine. Say like for cancer, for instance, if I can treat someone's nausea, they can do maybe chemotherapy or immunotherapy longer. And for ALS, I kind of view that the same way. If I can help someone's muscle spasms or fatigue or issues with producing too much secretions or saliva, or help them with sleeping or help their mood or anxiety, I feel like that they can be more successful for longer, maybe do maybe better with these medications for longer, or even be involved in things like clinical trial and things like that. So that's kind of my place, really. Yep.
Okay. Yeah, apart from the medications we talked about, the support like he offers, that's really important for the patients. And then, other specialists also play a significant role, physical therapists, occupational therapists. The most common cause of death will be respiratory failure. So respiratory support is absolutely important, especially even if it's just at night, to help, their breathing. That way they have more energy during the day. So people who, are under respiratory support do way better than those who are not. So all those, apart from, the medications that slow things down, the non-medication therapies and symptom management is also important and makes the patient very comfortable. I mean, at least so they get to enjoy the things they need to enjoy and do the things, remain functional for as long as possible.
All right, excellent. So definitely sounds like a teams-based approach where not just one person is dealing with all of this.
Yeah,
so,
exactly. Yeah.
Well, ALS can affect anyone, leading to loss of motor control throughout the body. It can be a slow, terrible disease to witness. One family in Brookings has been dealing with that for over 2 years. Prairie Doc reporter Sam Schauer shares with us their struggles with ALS.
Mark Crodeville is the husband to Patty, who suffers from ALS. They first noticed symptoms in 2020 from Patty falling downstairs, followed by slurred speech.
The doctor here didn't really know what it was. Finally, they figured it had to be neurological, and that's when they referred her.
Because of COVID-19, Patty's daughter Lori was with her every day, and she didn't recognize many of the signs.
I didn't see it as much because we saw each other so, every day and didn't see things progressing. And so when it was like, when things started being diagnosed, it was kind of like, well, how did that happen?
She went to Sioux Falls before being officially diagnosed with ALS in September of 2021. Soon after, she started to lose feeling in her left leg before spreading to both legs.
We walked until we couldn't walk anymore, but now we go to exercise 3 days a week at the Methodist Church and do that together.
Because of her inability to speak, she communicates through writing messages. She also must be assisted in many things in her day-to-day life, like a vest that shakes her lungs to help her breathe.
One of the problems with ALS is we understand that breathing problems, inability to control the muscles in your chest, and you can't breathe fully.
And while it's a struggle for Patty, she has a couple key pieces that help her keep going.
She says, my grandkids and my daughter and son-in-law help perk my spirit. They are pretty good treatment for both of us.
So are there symptoms that family members or people should be looking for that would make them suspicious for ALS or want to pursue that diagnosis further to make sure we're catching it in the earliest phases?
So the symptoms would be, the symptoms that would derive from the way the disease happens, which is, the death of the nerves that control voluntary muscles. So usually it will either start in the limbs, in the arm or in the leg. More commonly, less commonly, it can also start with the bulbar muscles, the muscles for speaking or swallowing. If it starts in the arm or upper extremities, then things like, hand muscle weakness, suddenly not being able to do the things, the person would be able to do. Usually we start in one arm and gradually, starts like the hand gradually progress to involve other muscles in that arm and then may spread to other muscles. If it's in the leg, then things like, someone who suddenly starts having a drop foot, feels like their foot is slapping the ground when they walk, or they are tripping over themselves suddenly, falling over suddenly where they cannot, explain it. So that would be weakness. Then the other common presentation will be, muscle twitching. Muscles, if they lose their nerve supply, begin to twitch, what we call fasciculations. Everybody's going to get a twitch now and then. 70% of the population will get a twitch. In some people, it becomes common. So one thing we try to reassure people is it's not every twitch that is ALS. It's not every weakness that is ALS. But if it's happening and it's not, going away, it's probably something the person should talk to their doctor, who would examine and look for other things that would point to the diagnosis. And then, of course, slurred speech or difficulty swallowing, if it involves the throat muscles. If those things, if anyone notices those things and it doesn't seem to be going away, they should probably talk to their primary doctor, and then who should be able to look at it and say, oh, I think I'm worried about this and we should have a neurologist see you.
All right. And viewers asking, is there anything that can be done to prevent ALS, especially like nutritional perspective, certain foods they need to eat or diet or?
There is nothing that we are certain that would prevent it. A lot of the time, 90% of the time is a sporadic thing that just happens, and we can't really say why. The only risk factors that that have clearly been proven would be the few people who have familiar ALS, which is uncommon, about 5% or at most 10%, and then age, and we can't change our age. Now, cigarette smoking data does suggest that it seems to be a little more common among cigarette smokers, and since smoking is not something that has any benefit anyway, so at least that's something that can be stopped. But otherwise, nutrition-wise, nothing else that has been proven to be a cause here that we would need to change to prevent it.
All right. Well, we have a Facebook viewer that stated that their mother died almost 40 years ago and she had ALS. Are there better treatments now than 40 years ago when her mother had this?
Yeah, certainly, like even if we go back 5-6 years ago, all we had was Reluxol. Now we have other medications. We have the edaveron, which used to be an infusion, now a tablet. We have the newly approved one. So we have more medications now that seem to slow it down. But more importantly, we understand it a little better, and we know that even the non-medication things, help in improving survival and patient comfort. Like you talked about respiratory support, talked about, the place of physical therapy, the place of palliative care. So all those things we have now. Unfortunately, 40 years ago, we didn't really know that much about this to offer that multidisciplinary, care. So, things are better now. And the good thing about where we are is that probably there's so much research going on now that I do feel more and more things are coming out. And even now, some of the genetic ones, there is a genetic therapy available, if it does turn out to be a familiar ALS and has maybe a certain mutation. There is a gene therapy that has just been approved as well.
Kind of like in my clinic especially too, like I feel like our communication advances have been really good, our symptom management advances, our care planning for the future, even like how people with ALS just sort of are able to be transported, maneuver, move, within their own homes or through the community. And then just the support systems that are just in place now. And then what we have just, again, to support sort of research and advancement is, way more than what we had all those years ago.
Excellent. Well, Dr. Juris, there's a perfect question that came in for you. It said, when a patient enters palliative care, how many times do they have visits, and what happens when they can no longer get to places or it's hard to get to these visits?
Sure. Well, so how I've been doing my clinic anyway, I tend to schedule folks with ALS to see me, and hopefully with their families as well, to see me pretty much every time they have ALS clinic, which tends to be about every 3 months or so, 3 or 4 months. so that we can talk about symptom management, talk about care planning, talk about the future, help with advanced directives, those kind of things. When those patients can't get to me, we do home visits if need be, go to nursing home, or if they might be out of town or just within the community because of weather or just health or whatever, we do telehealth, visits over the video camera.
Has that gotten easier after the pandemic now that we've all gotten used to Zoom and virtual visits?
I think so, actually. Yeah, and I think families and patients appreciate it. I think anybody hopes to get out of their home, and be able to be out in the community. But we try to do whatever we can for our patients. Excellent.
So, both of you, what types of resources are available to caregivers to help support when someone's diagnosed with ALS? Because I think a lot does fall on the family members as the disease progresses.
So, there is the ALS Association, which does, wonderful job. Every state has one, and luckily, South Dakota has a very strong ALS Association. They are, on point, reach out to the patient if anyone has this, and they get in touch with them. They at least support in terms of helping families understand better, because a lot of them are people who have had to deal with this themselves. So they have first-hand understanding of what these patients and their families are going through. And they have materials too, which they are often either providing or able to lend out. And the ALS clinics, there are social workers who would be there. We do have the social workers who, would often reach out to them, find out what they need, see how they can be helped with those things. We have the behavioral health people there too to help with their emotional support. So the thing would be, families being aware of these things that are available, and then utilizing them, just to help with coping with this disease.
Yeah, and I think additionally too, and I don't know if I can really name drop particular organizations outside of ALSA, but I think through the state, Dakota at Home, I think is an organization that's often used because you can have a caseworker, a case manager that can help to set up different types of in-home care with various agencies, even helping with respite for caregivers and care providers. And there are some agencies within the state that might help with if there are access needs, helping with building ramps or getting a different kind of shower or toilet or whatever within the home built, remodeling kind of things. There are some just various entities that sort of exist, and palliative medicine, but or ALS, utilizing your social worker can be really important, and that's why I always encourage folks with ALS to go to ALS clinic or or wherever they need to be, so that they can have that social worker support.
Excellent. So lots of things that are needed to help have people be successful in their own homes for as long as possible.
For sure.
Okay, excellent. Well, starting almost 15 years ago, the ALS clinic in Sioux Falls has helped many patients in their efforts to slow down the disease and provide easy access to all health professionals needed for the care in one location. Prairie Doc reporter Sam Schauer takes us to the clinic to see those efforts.
Becky Emerson is the coordinator for the ALS clinic in Sioux Falls. Her role is to help patients through the clinic and see all the needed specialists.
It's called a multidisciplinary clinic, and that means that there are several specialists involved in this clinic, each one focused on individual or different types of needs for the ALS patient as well as their caregiver.
The clinic meets once a month and can see around 5 to 6 patients from all over the region. A single patient usually comes every 3 months.
And depending on their status, again, sometimes we can stretch that out to 6 months, but just to touch base with them about every 3 months. Amazingly, things can really change in a matter of 3 months for these folks.
The clinic specialists help in a variety of ways, from respiratory and speech therapists to dietitians.
who helps see what the patient's nutritional status is. Are they losing weight? Do they now require a tube into their stomach for nutrition?
The clinic also provides care in movement-based therapy, like physical and occupational therapy.
They assess the patient's activity and abilities throughout the day, activities of daily living that we all take for granted that are becoming difficult as our arms and legs get weaker from that condition.
What benefits the patient is all the specialists are in a room together, and they can provide care or medication, which Emerson says is a big win for the patients.
To get all of these needs addressed in one setting is really remarkable. And eventually transportation becomes difficult for patients, and so to be able to get all these needs met and assessed in one setting is key for them.
All right, so kind of talking about the prognosis with this disease. So how long does a typical patient have from the time they're diagnosed to they pass away?
So on the average, life expectancy will be about 3 to 5 years from the time of diagnosis. Sometimes, some patients can live for much longer than that, but on the average, it's about 3 to 5 years from the time the diagnosis was made.
I think we have to talk about Stephen Hawking as one of those outliers that, so over 50 years that he lived with that diagnosis?
In the UK, they would use motor neuron disease. So, and motor neuron disease, like we said earlier, is a spectrum. So, and here we would specify ALS, and then the spectrum would include things like progressive muscular atrophy, which is a purely lower motor neuron thing that progresses slower. Primary lateral sclerosis, which again is a part of that spectrum that, life expectancy is in decades, not, so I, of course, don't have his medical record, so I don't know exactly what kind of motor neuron disease he had, because the UK, they would just classify it as motor neuron. Yeah. Okay.
All right. Well, ALS, what other diagnoses are commonly confused with or misdiagnosed or have to be on the differential when you're looking for those symptoms of ALS with the weakness and the twitching, and what other things do we need to rule out before we say, yep, it's ALS?
So, the usually, the mimics, we call them, or things we need to rule out would be maybe some myelopathies or, any compression of the spinal cord higher up in the cervical spine, which is why we would usually get MRIs, make sure there is no compressive pathology. Then sometimes some other things, but they usually won't have all the features. So things like Kennedy's disease, which is a hereditary muscular disorder, but that will be only lower motor neurons, but they can all have weakness, but on examination they will look a little different. But the key would be that, for ALS, the way it will involve multiple segments, there are very few things, almost, unless there are two diseases going on in the same person, it's difficult to find something that will do exactly what ALS does, unless someone has two different things, going on at the same time.
All right. Well, a viewer said, is there any genetic testing for this? Their mother passed away with ALS, and so did an aunt. They both died at age 62 and 64. This person's 59 and had a cousin that passed away very quickly. Is there any genetic testing to kind of see what your risk is with those family cases?
like we were saying earlier, the 90 to 95% of ALS would be sporadic, not familial. Now, about 5% will be familial, and there have been certain genes, that have been found to be found in familial ALS, things like C9 or CF9. I'm not even sure, I can't remember the name now. SOD mutations, certain mutations that have been seen in familial cases. That's why, again, an ALS clinic would include a genetic counselor, so that the family, they get that, in as much as we know that overwhelmingly, most of them are sporadic things that just happen that wouldn't happen to anybody else in the family. But there is always that, genetic testing is something that is so involved in that before we do it, we have a genetic counselor at least, speak with them, explain the genes that are possible, and then they can. So certainly, if someone has a family history of 2, then it's something that should be considered. Doing genetic testing, especially now that, like I mentioned, the SOD mutation. There is a gene therapy specifically developed for that, that is FDA approved. So if it turns out someone has that, there is, a different medication for it.
Okay, so it's very important information to get.
Yeah.
So talk with your regular doctor to say, I need a referral to a genetic counselor?
Yeah.
Okay, so that would be the person that could do that testing.
Yeah.
Okay, excellent. Well, Dr. Jarris, do ALS patients have any pain associated with the disease, especially as it progresses?
Truthfully, I've had some patients with almost no pain. Really, and I've had some patients that have had just kind of varying degrees of pain, kind of depending upon whether or not they have issues with spasms or neuropathy, like nerve type pain, I guess. And certainly we do kind of a variety of things to help to control or manage that pain to improve quality of life. Mm-hmm.
Excellent. And when someone is nearing the end of ALS, kind of talk us through what's that progression like? How do you know when they're getting close?
Honestly, standard of care for ALS really can include things like, breathing support, a breathing machine support, or a feeding tube. And sometimes it almost depends kind of what patients may or may not, as far as what they selected for their care. I think in terms of end of life, maybe selecting sort of hospice type care, and hospice certainly is a part of what palliative medicine does, but we're talking about someone in the last 6 months or maybe even the last year of life, really. There tends to be more of a focus on controlling things like any feelings of shortness of breath, helping out with pain, helping out with anxiety, especially if the anxiety and breathing are sort of kind of commingling with each other, if you will. And then just being very supportive of any sort of existential concerns, family concerns, things like that. And I think it can, again, depend upon, that management directly depends upon, is that patient needing just help with shortness of breath, or do they need help sort of transitioning away from a breathing machine, things like that.
Okay. Can you kind of explain to our viewers the difference between palliative care and hospice? I knew the terms get kind of thrown around interchangeably, but they are 2 separate and different entities.
Yeah. So, like I kind of mentioned, hospice is a part of palliative medicine, but palliative medicine is more of that focus on sort of chronic disease, chronic management, that extra layer blanket of care, supporting patients and families, helping them to navigate medical care, the medical system, symptom management, care planning, whereas hospice is really truly that focus on end-of-life care, that last 6 months of life, that last year of life, 2 physicians getting together to say we think this person has a terminal illness and that this terminal illness will take their life, and then sort of bring that team to them to support them. That, consists of nurses, aides, chaplaincy, pharmacy support, physicians, music support, massage. All kinds of wonderful people that come to the bedside to support patients and families throughout that journey.
Okay. So very. So when someone says, "I want to send you to palliative care," it's not saying that we've given up and we think you're going to die, which is honestly a common misconception that, oh, you're giving up, you're sending me to palliative care.
Yeah, I think in palliative care we really try to make sure we help people to sort of, not look at life in a different way, if you will, but try to maybe look at like hope in a different way. You know, sometimes people come in and they're like hoping for a cure, and hospice does this too, but it might be like hoping, you know, for that family get together, or hoping to be reconnected with that long lost son, or, you know, hoping to live to this event, or, you know, to just hoping to breathe, you know, I mean, just stuff like that. And that's what we help with. On both sides of that, actually.
Yeah.
Yeah.
Excellent.
Yep.
All right. Well, this has been a very informative. I think I've learned more about ALS than I did during medical school. So really appreciated both of you guys sharing this expertise with us tonight and our viewers. Like I said, it's not something that a lot of people know someone with compared to something like diabetes or migraines.
Right.
You know, so definitely we're glad that you were able to share this topic with our viewers.
Yeah.
Is there anything else that you see on the horizon for treatment of this or research?
So there are a couple of gene therapies going on, and because of the pathology, you know, understanding of the pathology, that it's neurotoxicity from different things. There are a couple of medications that have been tried to reduce that excitotoxicity. And it's a constantly going, ongoing process. And the way, you know, for a long time we only had Reluxor, and within a few years we are having more things. I do feel, you know, there are so many things on the horizon now which will suggest that there is hope, you know, for newer medications, especially with the gene therapy, you know, approach of, you know, that are being tried out now. Yeah.
Excellent. What's the most challenging thing that your patients have to face and deal with that you help?
I think it's just how ALS affects their lives. I mean, really. I mean, it affects their ability to work. It affects their families. It affects their children. It affects their mental health, their physical health, even their spiritual well-being. I think honestly that's probably one of the biggest things, or all the biggest things. Okay. So, yeah.
And Dr. Nnamdi, could you talk a little bit more about the gene therapy? How does that work? What's entailed with that?
So, you know, like earlier I was talking about the one that has been approved, which is the therapy for patients who have that SOD mutation. It's an intrathecal injection, and what it does, with ALS, there is you know, different hypotheses on the exact mechanism of neuronal death. We know the neurons die, but how it happens. So a lot of the gene therapy trials focus on trying to reduce the accumulation of abnormal proteins, like RNA messenger, RNA processing, you know, abnormal RNA processing leads to abnormal accumulation of proteins, which we'll see on autopsy of patients who have ALS. So there is a lot of focus on trying to, you know, see if we can reduce that abnormal accumulation of proteins. And the only one that has shown, you know, effectiveness is the tofersen, which is for the people with SOD mutation. And even the patients, we say there are 90% that are sporadic, but those still have some, you know, they still have, it's just that it's not familiar, but more of a spontaneous mutation. So these gene therapies may still be useful for them, you know, the more we get those available.
All right, well, last viewer question here. I think perfect one for Dr. Juris. It said, do you see a lot of mental health issues surrounding the diagnosis, especially since there is no cure?
Yeah, I mean, I think a lot of patients that sort of come to clinic, you know, fortunately, a lot of them have gone to ALS clinic. They've had a lot of information, education, sort of, you know, just introduction in general. But I think, you know, when they do come to clinic, there tends to be, well, low mood. I mean, for a lot of reasons, right? And then I think a lot of anxiety about just the future, about, you know, whatever's going on at the time, swallowing difficulties, breathing difficulties, pain control, you know, the future, things like that. So But yeah, I think mental health plays a big part, so talking that through with patients, helping with medications, counseling, referring for counseling, whatever we need to do, making sure they have their spiritual support, of course, as well.
All right.
Yeah, team approach.
Okay.
Yeah.
Well, wonderful. Well, I think this is the perfect close to a wonderful discussion this evening. You both were very eloquent, and thank you so much for sharing your expertise here. So, the winner of our prize tonight is Diane from Brookings. Thank you, Diane, for asking a question during the first 20 minutes of the show. A gift will be sent to you. We'll be back after this.
Have you downloaded and subscribed to the Prairie Doc podcast? Health professionals join host Laura Ellsworth each week to discuss and take questions about timely medical information. Search Prairie Doc on Apple, Spotify, SoundCloud, or wherever you find podcasts today.
On July 4th, 1939, Lou Gehrig said these famous words at Yankee Stadium. For the past 2 weeks, you have been reading about the bad break I got. Yet today, I consider myself the luckiest man on the face of the earth. The bad break he was referring to was the diagnosis of a condition that would become synonymous with him, a neuromuscular condition called amyotrophic lateral sclerosis, or ALS. ALS is a disease which causes motor nerves in the brain and spinal cord to break down. This reduces the nerve's ability to control muscle function, leading to muscle weakness, twitching, and wasting away. As the disease progresses, it slowly impairs the person's ability to walk, talk, swallow, and breathe. Lou Gehrig was only 36 years old when he was diagnosed at the Mayo Clinic in Rochester, Minnesota. However, it is more commonly diagnosed between the ages of 55 and 75. He lived less than 2 years after his diagnosis with ALS. Today, the average life expectancy after diagnosis is 2 to 5 years. But some people with this disease can live much longer. The famous physicist Stephen Hawking lived for more than 50 years after he was diagnosed with ALS. The cause of ALS is still unknown. Almost all cases are considered sporadic, while only 5 to 10% are thought to be inherited. One study suggested smoking may increase a person's risk for developing ALS. Military veterans also have an increased risk of developing ALS compared to civilians. Currently, there is no single test that can predict or diagnose ALS. It is based on symptoms and a multitude of tests. While there are treatments and medications that can slow the progression of the disease, there is no cure. But research is still ongoing. Over 80 years later, the final words of Lou Gehrig's speech still serve as inspiration. So, I close by saying that I may have had a tough break, but I have an awful lot to live for. Major League Baseball holds Lou Gehrig Day every year on June 2nd. That day marks both the anniversary of when he became the starting first baseman for the New York Yankees and the day he passed away in 1941. On this day, Major League Baseball raises funds to help research ALS, to find better treatments, and hopefully find a cure. Lou Gehrig's optimism and tenacity in the face of such a life-changing diagnosis makes it no wonder that most people know ALS as Lou Gehrig's disease. Well, thank you to our guests, Dr. Jairus and Dr. Uhegwu, for volunteering their time to help us learn more about ALS. If you would like to see and hear more episodes of this program, please like and follow us on Facebook, Instagram, and YouTube, or visit us at prairiedoc.org. Look for Prairie Doc Perspectives in your local newspaper and online. and listen to us live every Wednesday mornings at 9:30 on KBRK Brookings or online. And be sure to look for the podcast of this program, Prairie Doc On Call, wherever podcasts can be found. From all of us here at On Call with the Prairie Doc, thanks for joining us for another episode of Health Information based on science, built on trust. Until next time, stay healthy out there, people.
Breast cancer survival rates have increased and deaths are on the decline. Learn about a new personalized approach to treatment and research. Beating breast cancer, next time on Call with the Prairie Doc.
I'm Carter Home, and I have been a nurse for about 8.5 years. Worked for the first half of my career in a nursing home, but now I'm at Avera McKinnon inpatient rehab. My dad worked with On Call at the Prairie Doc and started the Healing Words Foundation, and after he passed, we decided as a family that we would take turns on the board to represent what we feel is our dad's best wishes. So I feel like I've been involved with it my whole life, but specifically the last 2 years working on the board. It's an incredible resource for our community, and with the hard work of the volunteers, we're providing a resource to the community of South Dakota that is pretty rare to help prevent people from needing to go to the hospital, to prevent the spread of misinformation. Providing that science-based approach really was a passion of my dad's and something that we're really honored to continue. It gives people that first step because it's a way that we can talk to our physician without having to make an appointment or having to wait or having to, frankly, spend any money. A free service to help provide information, helping prevent potential hospital stays or more serious health issues. My dad was a physician, my mom a nurse practitioner. When I graduated from high school, the one thing I knew was I did not want to go into medicine. And then as I grew and matured, the idea of having a stable career that allowed me to help people became sort of my driving focus. And On Call with the Prairie Doc started so long ago with the idea of helping people. It has inspired me in that, I'm a professional nurse, but I'm a helper first and foremost. For more information or to donate, go to www.prairiedoc.org or send your donations to Post Office Box 752, Brookings, South Dakota 57006. Thank you for your support.
Major funding for On Call with the Prairie Doc has been provided by
At Avera, our nationally recognized health system will be right here with you, with care and coverage. Hello, possibility. Hello, healthy.
Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information. And with the ongoing support of these individuals and institutions, Brookings Health System, Ophthalmology Limited, South Dakota Academy of Family Physicians, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Vance Thompson Vision, Monument Health, Black Hills Medical Society, Brookings Madison Flandreau District Medical Society, Pierre District Medical Society, Sioux Falls District Medical Society, Yankton District Medical Society, Orthopedic Institute, Lake Poncet Sailing Academy, Aberdeen Asthma and Allergy, Dakota Bank, South Dakota American College of Physicians, and Swiftel Communications.